Yes.
Yes.
That.
Yeah, brilliant.
Yeah, brilliant.
Over to you.
There.
Over to you.
So you can see me there?
Yes,
Yeah, yeah.
we can.
Yeah.
I'll take it again. Thank you for the opportunity to speak from the States, where we're celebrating Thanksgiving here, the American Thanksgiving.
It's a
It's a pleasure.
And just a brief period of time, providing a little bit of update on renal failure and ECMO support. I just wanted to add, I have relevant financial arrangements just to disclose. We'll be discussing off-label use on products related to the delivery of CRRT. I wanted to share this interesting description of distillation of poor fluid device. Just was spending a little time actually deliver that first bottle to my grandmother's. So, you might think of this as a way we progress through life. What I wanted to try to do in the brief period of time I had was to go to one questions. First, what is the incidence of kidney injury and impact on outcome in ECMO? Second, validity, like CRRT, replacement therapy, help in ECMO patients. And thirdly, what is the impact of CRRT on outcome in ECMO? I'll start with just looking at acute kidney injury in ECMO patients. And what we do know is that kidney injury is very common in ECMO patients. That theory demonstrates somewhere in the range of 70 to 80% of children and adults who go on ECMO have some degree of kidney injury. Very common. We also know that patients on ECMO who have an association with increased mortality, even when controlling for confounders of other severity of injury scores. In the LSO registry itself, we've seen an independent increased risk of mortality with acute kidney injury. That's based on an ICD-9 code, international diagnostic code, or urine creatinine greater than 1.5 milligrams per deciliter. So chronic renal injury from adding renal support therapy. So, just as a reminder, non-ECMO renal replacement therapies have similar outcomes, somewhere in the 15% survival and 90% recovery. So, comparing ECMO patients and CRRT, there's not a significant difference versus patients who do not go on ECMO get renal replacement therapy. And again, to try to separate this out, a recent paper, this is about to be published now by Dr. McLaren of Melbourne. They did a propensity study matching in one of their Melbourne ICUs, matching patients who received ECMO versus those who got ECMO plus CRRT. What they found was patients with ECMO plus CRRT had significant improvement in fluid count. They also found that those patients that had CRRT added, you might have expected a higher ECMO rate. Of note, though, propensity matched, there was no difference in ICU or hospital survival. And there was no difference in either adults or children excluding that effect. So these were patients who were sicker patients who had CRRT and no worsening of survival. Again, another study recently that suggested it's not CRRT itself, but fluid overload or AKI. This was a patient group, in pediatric patient group, looking at fluid overload and initiation discontinuation of series. What they found was the fluid overload itself that was associated with increased mortality. That's all consistent with all previous studies, including ones. This effect was independent of the CRRT itself. That is, taking that out of the picture, it all came down to how sick they were when they came into that ECMO situation when they had CRRT. Again, this support, the evidence in this study supported the fact that early intervention prior to fluid overload development created the best strategy. So, encouragement is there to intervene to try to avoid fluid overload, but possible aggressive use of diuretics or CRRT before they had a more serious level. And finally, the argument of CRRT, how do you do? There are two things. One is to basically insert a hemofilter in line in the ECMO circuit. The problem with that is that you get significant fluid discrepancy. Here at our center, we demonstrated you get 10 to 20% difference in which you can just hook up a urometer-based system and attempt to pump fluid in to replace what's coming out as ultrafiltrate. So you have a tendency to get more dehydrated than you think you are. In this KidMO ECMO survey, about 33%, or 2/3 of the centers actually have gone to adding a commercial CRRT device into the system rather than just adding a filter. The commercial system, Prismaflex or Braun, those systems allow you to manage, control those fluid balances there. This is just a diagram, and by the way, I've provided all these slides. Hopefully those will be available through the SWAC, also through for anyone to review. But this is the free-flowing mechanism which a hemofilter is inserted and fluid is pumped in to match, the filter is pumped in to match what is draining out. The problem here is that the measurements can be misleading. Different approaches actually integrated or adding in an automated system to it, whether it's going to be commercially available or some new devices that have been developed for children, including Dr. Ronco putting together a piece of equipment out of Italy, the U.S. Here at Children's are also working on this pediatric device. So in summary, acute kidney injury is common in ECMO patients associated with increased mortality. CRRT could theoretically provide benefits on ECMO, particularly if it's provided early in the course of illness. The impact of CRRT on ECMO outcome remains controversial and still needs severity KI adjusted. There are further studies in progress to try to really sort this question out. In particular, adult studies are lacking. There's probably a real opportunity here to evaluate it better in the adult population. So I go back to my 4 clues of why I would suggest that ask whether CRRT can also be one of those devices to help add and improve on.
Thanks.
With that, I would open it to questions. I appreciate your listening again and the honor of being asked to present to you. Talking down to how sick they were when they came into that ECMO situation when they had CRRT. Again, this support, the evidence in this study supported the fact that early intervention prior to fluid overload development created the best strategy. So encouragement is there to intervene to try to avoid fluid overload, but if possible, aggressive use of diuretics or CRRT before they had a more serious level. And finally, the argument of CRRT, how do you do There are two basic ways. One is to basically insert a hemofilter in line in the ECMO circuit. The problem with that is that you get significant fluid discrepancy. Here at our center, we demonstrated you get 10 to 20% difference in which you can just hook up a urometer-based system and attempt to pump fluid in to replace what's coming out of such a filtrate. So you have a tendency to get more dehydrated than you think you are. In this KidMO ECMO survey, about 33%, or 2/3 of the centers actually have gone to adding a commercial CRRT device into the system rather than just adding a filter. The commercial system with Prismaplex or Braun, those systems allow you to manage, control those fluid balances. This is just a diagram, and by the way, I've provided all these slides. Hopefully those will be available through the SWAC also group for anyone to review. But this is free flowing mechanism which a hemofilter is inserted and fluid is pumped in to match, those filters pumped in to match what is draining out. The problem here is that the measurements can be misleading. A different approach is actually integrated or adding in an automated system to that, whether it's going to be commercially available on the course of new devices that are developed for children, including Dr. Ronco putting together a piece of equipment out of Italy. In the U.S., we here at Children's are also working on this pediatric device. So in summary, acute kidney injury is common in ECMO patients associated with increased mortality. CRRT could theoretically provide benefits on ECMO, particularly if it's provided early in the course of illness. The impact of CRRT on ECMO outcomes remains controversial and still needs severity and KI adjusted. There are further studies in progress to try to really sort this question out. In particular, adult studies are lacking. There's probably a real opportunity here to evaluate it better in the adult population. So I go back to my 4 fluids of life and suggest that I can ask whether CRRT can also be one of those devices of life to help add and improve life.
Thanks a lot.
With that, I would open it to questions. I appreciate your listening again, the honor of being asked to present to you.
Thanks, Jim. Thanks a lot for sharing the data with us. I think the message is very clear. Avoid fluid overload and use appropriate therapies like CRRT at the right time, optimal time, as far as possible.
Exactly. I think that is the most important message. And one important message is that while we utilize CRRT as a device for hemofilter, that attention, that very strict attention to fluid overload early in the course of illness in general appears to be associated with outcomes, not just in patients on ECMO, but prior to ECMO. So that aggressive management of fluids to avoid that, and that may be through restricting fluids once you do initial resuscitation, or very aggressive use of diuretics can also be helpful, even absent utilizing CRRT device.
Thank you. Dr. Vivek has a question.
Good evening, sir. Sir, theoretically, we all know that CRRT should be started early for a better results. But what practical criteria you take to initiate CRRT when a patient is on ECMO?
That's an excellent question. We, the KidMO group is actually trying to work on really sorting that out on ECMO. We have some data out of our own institution. Patients who the mortality jumps up in patients who are more than 20% fluid overloaded, and that when we measure that, it's just the difference between input and output divided by their weight. So if they're point that they're in the 10 to 20% fluid overload range, we would be instituting CRRT in our institution. We're very aggressive in general with our ECMO patients and most ECMO patients here in Atlanta. We will go ahead and put some kind of CRRT device in line unless we anticipate they're going to be on for maybe 24 to 48 hours. But we're more aggressive in some centers that will wait to see what the fluid overload is. And we're believers that the earlier the better. So we jump in very early. But the reality is that most patients, by the time they end up on ECMO, are probably in that range anyway, that 10 to 20% range. So those are the sort of numbers that we look for.
Okay.
Thank you, sir. And one more question. We talked about the inline CRRT. Is there any experience that we instituted CRRT separately? Is there any benefit or
benefit of using a separate device?
Yeah.
Yes, there's not, to my knowledge, there's not a comparison between the two groups. There is some data from single institutions that their outcomes were better when they switched from just a simple inline filter to adding a device like, say, Prismaflex or one of those devices. And I mentioned I have no commercial interest or anything like that. But those are, I'm not sure what's available in Prismaflex.
Yeah, Prismaflex is available. It's available.
The suggestion would be that the outcomes would be better because you can manage, you can control more accurately how much fluid you're removing. What we found, particularly in small children, is that simply putting an inline filter in and hooking it to a urometer, that we were not drank more than we thought we were. We went and actually did the calculation. We had an engineer from Georgia Tech work with us and measure the actual losses. And so we may have been too aggressive in our dehydration. So I would say probably my bet is that the data is going to show that adding the device in helps compared to
Thank you, sir. Thanks.
Any other questions? If not, thanks a lot, Jim, for sharing your time with us, and I express my gratitude for being with us at this odd hour on Thanksgiving Day. We're all looking forward to seeing you here in February 2015. Thank you very much and good night.
Thank you so much, and thank you for your patience as I got set up here.
Thank you.
Thank you.
Something that you can write that way you before I
Venkat, ECMO for Mary.
okay. How much time? Fluid line is coming in how much time? How much time do you have?
15 minutes also.
He is going to go after 11:20. I can plug my
Yeah,
two things together.
Sure.
Time is already late.
sure.